Honorable Vice Principal Sir, respected teachers, dear colleagues, beloved intern doctors, me Dr. Susti Sarkar, on behalf of Department of Dermatology, welcome you all to today's scientific seminar on clinical approach to blistering dermatosis. Our today's session will be chaired by Dr. Nahida Islam, Associate Professor and Head, Department of Dermatology. Resource person is Dr. Mohammad Shahidul Islam, Associate Professor, Department of Dermatology. Our today's speaker is Dr. Sadia Rubana Nila, Registrar, Department of Dermatology. Now I would like to request our today's chairperson, Madam, come to the dais with resource person and conduct rest of the session. Thank you all.
Assalamu alaikum. I hope all are well. Now I am really glad to your kind presence today, beautiful morning. Now I would like to start our scientific seminar. Will be held on clinical approach to blistering dermatosis. Now Dr. Sadia Rubana Nila, Registrar, Department of Dermatology and Venereology, is being requested come to the dais and conduct the rest of the session.
Thank you, Madam. Assalamu alaikum. I am Dr. Sadia Rubana Nila. With kind permission of chairperson, would like to present my topic. My today's topic is clinical approach to blistering dermatosis. Blistering dermatoses are skin conditions characterized by blister formation. A blister is an accumulation of fluid between cells of the epidermis or upper dermis. Causes of blister could be genetic, physical, inflammatory, immunologic, and as a reaction to drugs. They are mostly autoimmune. Causes. There are some congenital and some acquired causes. Congenital causes are epidermolysis bullosa, Hailey-Hailey disease, Derrier's disease, incontinentia pigmenti, congenital syphilis, congenital bullous ichthyosiform erythroderma. Acquired causes are infective causes, bacterial causes, bullous impetigo, impetigo contagiosa, Staphylococcus scalded skin syndrome. Viral causes, herpes simplex, herpes zoster, chicken pox. Fungal causes are Tinea pedis and Tinea pruris. Ectoparasitic scabies. Immunological causes, they are pemphigus group of diseases, bullous pemphigoid, pemphigoid gestationis, cicatricial pemphigoid, epidermolysis bullosa acquisita, dermatitis herpetiformis, linear immunoglobulin A bullous dermatosis, and chronic bullous disease of childhood. Metabolic causes are porphyria cutanea tarda and diabetes. Physical and chemical causes, contact dermatitis, burn, insect, acid alkali, vaccination, radiodermatitis. Others causes, bullous acili, bullous erythema multiforme, bullous lichen planus, bullous drug eruption, and toxic epidermal necrolysis. Now, the mechanism of blister formation. There are 5 mechanisms by which blisters are formed in skin. They are spongiosis, acantholysis, reticular degeneration, cytolysis, and basement membrane zone destruction. Clinical approach. We diagnose the patient through history and clinical examination. History, taken thorough history including age of onset, initial site, and drug history. Clinical examination includes mucosal involvement, distribution of lesions, morphology of lesions, configuration that is grouping or some other characteristic sign or pattern, Nikolsky sign, Asbu-Hansen sign. Now some cases are presenting here about the blistering dermatosis. Case 1, our patient Mrs. Onufa, 45 years old housewife, normotensive, non-diabetic, hailing from Sripur, Gazipur, admitted in dermatology department of CBMCB with the complaints of multiple blisters in different parts of the body for 6 to 7 months. Initially, the blisters were few, started over the back of the body, but gradually appeared in the abdomen, forehead, and skull. The blisters were thin-walled, and some of the blisters ruptured spontaneously, forming erosions with oozing. Later on, some lesions became covered with crust. For last 1 month, she also noticed few blisters over gum that ruptured to form painful erosions. There is no history of fever, joint pain, and taking any drugs responsible for this lesion. Nikolsky and Asbu-Hansen sign are positive. Investigation. Skin biopsy for histopathology done. Epidermis shows a bulla containing acantholytic cells and eosinophils. Janksmear and direct immunofluorescence could be done. This is our patient showing blisters and crust over forehead, abdomen. There are some intact blisters, they are thin walled, and there is some lesions. They are showing crust and healing with hyperpigmentation, and some are coalescing to form confluent lesions. And this is the mucosal gingival erosions. After taking proper history, doing physical examination and investigations, the patient was diagnosed as a case of pemphigus vulgaris. Treatment given, daily bath to remove crust, antiseptic mouthwash, antibiotic both topical and systemic, intravenous methylprednisolone and intravenous cyclophosphamide. Case 2. Mr. Jihad Ali, 70 years old normotensive non-diabetic patient, came to dermatology outpatient department with the complaints of multiple vesicles over the right side of the forehead, including right eye, with severe pain and burning sensation for 5 days. On inspection, there was multiple vesicle with overlying hyperpigmented crust present unilaterally on right ophthalmic division of dermatome. There was also swelling of right eyelid involving right cheek. Investigation could be done, Jank test, culture, polymerase chain reaction, and skin biopsy for histopathology. This is the before and after picture of this patient. Based on history and clinical examination, patient was diagnosed as a case of herpes zoster ophthalmicus. Treatment given, tablet valacyclovir, tablet amitriptyline, capsule pregabalin, and care of eye given, done with consultation with ophthalmology department. Case 3. Mrs. Sumaya, 25 years old housewife, hailing from Nalitabari, admitted in dermatology department of CBMCB with the complaints of multiple blisters over face, including oral cavity, lips, upper limb for 4 days. Patient also complained of fever before the eruption of this lesion. Lesions were erythematous and necrosed in some parts. Lips were crusted. Lesions of the oral cavity were painful. Patient feel pain during swallowing and micturition. Erosion present on anal and genital area. Nikolsky sign was positive. Patient was hypertensive, non-diabetic. On query, the patient informed that She took some medications before eruption of the lesion. And this is the necrosed lip and necrosed lesion over nostrils and upper limb. Investigation done, complete blood count, liver function test, renal function test, and urine for routine microscopical examination. Based on history and clinical examination, patient diagnosed as Stevens-Johnson syndrome. Treatment given, bed rest, nutritional support, antiseptic mouthwash, intravenous dexamethasone, and oral cyclosporine. Case 4. 2 years old baby boy come with the complaints of blisters over right upper limb for 3 days. According to mother's statement, blisters first appeared over face, around the mouth and nose, then spread on limbs. Blister ruptured quickly and formed yellow crust after drying. Lesions were painless but mild itching present. On inspection, discrete thin-walled bulla and some erythematous crusted lesion with oozing over face and limb. There were no history of fever or taking any drug responsible for this type of lesion. This is the picture of the baby. Some erosion and crust over the face and tense discrete bulla over the limb. The baby was diagnosed as bullous impetigo. Treatment given, topical mupirocin ointment and systemic cephradine. Case 5. Abdul Barek, 90 years old farmer, normotensive non-diabetic patient, hailing from Kathal, Trishal, presented with multiple blisters over both foot for 3 to 4 months. Most of the blisters are large and tense. Some blisters have ruptured, leaving denuded area that healed spontaneously. Some healed areas shows hyperpigmentation with scarring. There is no involvement of the other part of the body, mouth or genitalia. Patient also complains of mild itching over the area for same duration. He had similar attack 1 year back and recovered completely. Nikolsky and Asbu-Hansen signs are negative. There is no history of fever, joint pain, muscle pain or intake of any drugs prior to the appearance of the blister. Here some large and tense blister and hyperpigmented area, they are healed but there is some scarring present on the foot. Investigations, complete blood count, random blood sugar, Jank test and skin biopsy for histopathology and direct immunofluorescence test. The patient was diagnosed as bullous pemphigoid. Treatment, bed rest, adequate nutrition, antibiotic, antihistamine, oral prednisolone and oral cyclophosphamide. Case 6. A 3 years old male child presented with history of recurrent blisters from last 8 months. It was insidious in onset, gradually progressive to involve trunk and extremities, including genital area and medial thigh. Most of the blisters used to rupture spontaneously with oozing of clear fluid and leaving denuded areas. New crops of lesions used to appear along the periphery of healed or crusted lesions. There was no history of prior drug intake, trauma, consanguinity or similar lesions in the family. A general physical and systemic examination was normal. Dermatological examination revealed multiple tense, discrete, as well as confluent vesicles, bulla, and few erosions all over the body, more intensively distributed over the perineal region and lower limb. Palm, sole, and genital mucosa were spared. The characteristic string of pearl sign was seen in many sites. This is the characteristic string of pearl sign, vesicles in a pattern of pearl string. Patient diagnosed as a case of chronic bullous disease of childhood. Treatment given Jackson. Now, here is the total amount of patient admitted in dermatology department in this year, not completed this year. এই পর্যন্ত যে কয়জন পেশেন্ট ভর্তি আছে তারই একটা সামারি স্যার এখানে আমরা দিয়েছি। টোটাল পেশেন্ট ছিল আছে এখন পর্যন্ত পেশেন্ট ভর্তি আছে 3 জন। এর মাঝে 86 পেশেন্টের মাঝে 27 পেশেন্টই হচ্ছে ব্লিস্টারিং ডার্মাটোসিসের। এবং এই পেশেন্টগুলোর মাঝে স্যার অটোইমিউন পেশেন্ট আমাদের যে পেশেন্টগুলো ভর্তি ছিল তার মাঝে 14 পেশেন্ট হচ্ছে অটোইমিউন কজ, ড্রাগ রিঅ্যাকশন 6 পেশেন্ট, হার্পিস জোস্টার 5, chickenpox 1 patient was admitted, and insect bite hypersensitivity 1 patient. And these are some other patients showing the same diseases but in degree of involvement. This is the severe case. This is the severe case of a pemphigus vulgaris patient, but the patient improved by treatment. And this is the patient. This patient is also on our treatment. She is receiving our pulse therapy of pemphigus vulgaris and methylprednisolone pulse therapy টা পাচ্ছে স্যার। এই পেশেন্ট দুইজনই এখন ইমপ্রুভড, ভালো আছে। These are other patients in our outpatient department treatment. এই পেশেন্টগুলো ভর্তি ছিল না কিন্তু স্যার আমরা পিকচারগুলো কালেক্ট করে রেখেছি। This patient was admitted in our department. This is a case of insect bite hypersensitivity. This is the vesicular eruption with the kissing lesions and the erythematous area. And this is the vesicle of insect bite. এগুলো স্যার outpatient departmental patient. This is a patient of Stevens-Johnson syndrome. But patient severity কম ছিল, only oral mucous membrane involved ছিল আর স্কিনে lesion ছিল। And these are other patients of burn blister, diabetic bulla and friction blisters. At last, thank you for your attention. Thank you.